This is definitely all of you can appreciate it, right? This is nystagmus. Anything you observe here? So I'll play this again. This is the nystagmus. Rapid eye movement. If you carefully observe the nystagmus, the level of nystagmus, both amplitude and the frequency, is much more on the right gaze than the left gaze. Okay, I'm coming back because this patient was diagnosed to have infantile nystagmus. And the patient has other things which he told he is not able to write as before. His handwriting is deteriorating day by day. He's trying to write his name. Sometimes the teacher is not understanding what exactly is going on. So coming back to this patient was diagnosed to have infantile nystagmus or the congenital nystagmus, what you call, and abnormal head posture, that is the right face turn. What we saw on the video was the frequency was much more on the right gaze and it's less on the left gaze. It's very, very typical of one of the problems in the brain, that is a CP angle tumor. We call as Bruns nystagmus. Obviously, the patient had the MRI. You can definitely see a very large mass involving the CP angle. I hope it's pretty clear. It's even causing a midline shift. Why I wanted to show this case is stepwise and the comprehensive examination is important. Okay, this patient underwent some kind of excision and also radiotherapy. You can see the tumor size has shrunk now, and he comes again after some time. The nystagmus in the primary position is stable, but you can still see the nystagmus is, kind of still there, that typical nystagmus. And also he has this typical facial palsy, which can be associated. Again, these are all examination which can happen with 30 seconds if you're observant. Obviously, his handwriting has improved post-therapy. This is not possible to improve everything here with the CP angle, but to some extent it has improved. Second case, this is diagnosed to have blepharotosis, which is congenital, but the child is doing this and they are so desperate to see. Sometimes they lift their lids also. But look at what is happening in the old pictures. This is not there since birth. What this child had was a very typical myasthenia. Because of that, there are other things which will not go into ptosis part and all that. There are therapeutic kind of evaluation for ptosis and some are diagnostic. So if you see the diagnostic, the patient has a very good lid crease and frontalis overaction. Why am I showing a lid in the strabismus? Because lid, pupil and ocular motility, they go hand in hand. So always remember LMP. When lid is abnormal, see the ocular motility M and also pupil. These are important to check. So this is one more patient, comes with the abnormal head posture. Right face turn, you can see very well, right? Everything was normal. No nystagmus, no refractive error, no ptosis, no field defect. But what was the culprit here? You can see very well, significant scratch on the glasses. So abnormal head posture is not always due to strabismus. Just remember that. We have to observe other things as well. This is typically nystagmus with abnormal head posture to right side and also left side. We call it call it as periodic alternating nystagmus. So the first part of the thing with these cases I would like to come is the history taking. What history taking we should be taking in a case of strabismus. Strabismus is one of the symptoms or one of the ocular manifestation of many diseases which can happen. Most of us think that it's comitant, it is benign. But when a case comes, you have to derive and come to a conclusion that it's comitant or incomitant. Is it a benign comitant or is it something really dangerous? Sometimes it can be life-saving, sometimes it can be sight-saving. So you need to remember. So the birth history and developmental history is a mandatory thing in all the patients. In most of the comitant strabismus, I would say, even if they come late during their adulthood. Duration and progression is a part and parcel of any history taking. What's the duration of the strabismus, whether it is progressing, whether it is associated with double vision. Double vision is very, very important to ask. With this, you can come to a conclusion, whether it is horizontal or vertical, or is it torsional. Depending upon that, you can come to a conclusion. And three other associations I have put here, which you wouldn't ask in every patient, but most of the patients you need to ask for the systemic condition. Like infantile esotropy with this patient comes, you need to ask for neurological association, whether there is any developmental delay or whether there is any systemic disease like Down syndrome. A patient coming with the double vision, you need to ask whether the patient has any thyroid eye disease, hypertension, diabetes. All these things becomes important because most of us as a resident or general practitioners, what we see double vision is most often it's because of trauma, traumatic palsy, or because of any kind of ischemia due to hypertension and diabetes. Most commonly, ischemic sixth nerve palsy and ischemic third nerve palsy. And obviously, in elderly patients, we also have to think about any kind of aneurysm. So it's a plethora of disease which can present as strabismus. In the birth history and development, it can be congenital cataract, unilateral cataract coming as strabismus. Sometimes it can be retinoblastoma, very rarely. These are all manifestations. So they don't come with these kind of things. So you need to do, why am I stressing on this part is, just don't do strabismus evaluation, do a complete history, look at systemic, neurological and other ocular association, and then go to a kind of examination. Once you have this in place, then you can think about which way I'm going. Okay, there is no neurological association, it's good. The patient does not have seizures, headache, vomiting. So I'm kind of ruling out neurological cause, not always, but most of the times. Whether the patient has diplopia or not, whether the patient had any prior ocular surgery. History taking also is important in terms of any previous ocular or non-ocular surgery, including strabismus surgery in the past. This is also for us to see, because sometimes strabismus surgery history is not taken, then we will associate with some neurological disease. This has to be taken. So I have just put 7 points here, but I can just talk about history taking with different examples for half an hour, which we can all do for any kind of disease. But on top of your mind, just think about developmental history, birth history, duration, progression, associated double vision is there or not. And then 3 types of association: systemic, neurological, and any ocular association. And this is important as being a pediatric ophthalmologist or strabismologist. You need to have, this patient is crying and crying. He is not able to allowing us to do anything. cover test is not possible all the time, but you can have surrogate measures, like you can have a simple toy like this, which can be there in your pocket. We can make sure that child is attentive. Sometimes even you have to use your thumb to do a cover test. It's not possible to get everything like cover test, uncover test, prism cover test, alternate cover test, ocular motility, ductions and versions. It's not possible. It's ideal. It's not possible in these kind of children, which is not most of the kids, they cooperate, but some kind of toys, it's always handy. I will come to a bit in the abnormal head posture. I would like to show some more. Before that, the residents most often get confused with squint means cover, uncover, alternate, latent, manifest, and fusion. With these 6 words, their vertigo and spinning in the head already starts. But one thing I must tell you, which happened to all of us when we were residents, while reading strabismus, you understand everything. What is ARC, what is NRA, what is amplitude of accommodation, everything. But the minute you complete 3 or 4 days, when a patient comes and sitting in front of your, clinic or in front of your chair, you think, okay, simple, can you tell me what is cover test and uncover test? It gets confusing and confusing. Why? The basic reason is you don't apply it. So these tests, uncovering the cover test is not difficult. I'm going to show some videos either today and maybe in the next class. But you need to understand what you're doing and why you're doing. And it just, again, observation. Only thing that moves is your hand and the cover. With that, your eyes also moves. With that, you need to come to a conclusion what it is. I basically always, for the ease of understanding, I kind of classify strabismus and ocular motility evaluation, both in kids and in adults, as diagnostic test and therapeutic test. Textbook says in a different way, but for ease of understanding, diagnostic is like, okay, whether the patient has esotropia. Yes, patient has esotropia. Is it comitant or incomitant? When you see that incomitant, if you see retraction, it's mostly towards divan retraction. If you see any kind of nystagmus, you go in terms of nystagmus and strabismus. So Hirschberg, HBT is Hirschberg test, cover test, and motility. Especially, these are the diagnostic tests. In terms of therapeutic test, you need to know what is happening. Like you have given a therapy for some patient, ocular myasthenia, for example. Patient has hypertropia. It was 15 to begin with. You need to measure it. Next time when he comes, okay, it has come down to 7. That's good that the patient is recovering. You have to do a surgery for a 30 PD. When the post-op patient comes, you need to do this prism cover test. And when you're doing more and more therapeutic test, you don't care about cover test, uncover test. It's not really practically required. What you do mostly is prism cover test. And then if the vision is very poor, then you do Krimsky's test. So, but one thing, when you are doing an evaluation of strabismus in a child, it's always visual acuity estimation as well. Sometimes, when you put your thumb, you're doing it for, eliciting the direction of the ocular movement, but also you can check whether the fixation is central, steady, or maintained. It's not that in infants and toddlers, you cannot separate visual acuity estimation and also strabismus evaluation. So they go hand in hand, both uniocular as well as binocular. You will get With the rapidity of fixation, you will know whether the patient has amblyopia or lazy eye as well. And if you can't get all the information, patch one eye and then see the response. Maybe patch the worst eye first and then do the other eye. I'm not going to talk about visual acuity estimation in children, especially in infants and toddlers, but this factor, you need to keep it in mind before you decide on what test to do. Again, I said the inspection and observation is very, very important. This we have heard from MBBS days. In any disease, it's not applying to strabismus. You may have a patient with proptosis with thyroid eye disease. He may be walking like that. You may have ocular myasthenia, or you may have a third nerve palsy or a supranuclear palsy. By the way they walk, you can imagine or understand why this patient has come. That kind of checklist, that kind of, I wouldn't say artificial intelligence. You need to acquire this by seeing 100 plus or 200 plus patients. This has to go in when they come to your clinic. For example, there are face turn patients here. So the first patient is because of the cysticercosis in the muscle. He is having the the face turn to the right. And you can also see the congestion there. Face turn is not always because of nystagmus. As you can see in the child on the right side, that child has nystagmus. And the lowermost child has a right face turn. This patient has Duane syndrome, with which the patient has come. So inspection is important. Don't come to a conclusion, okay, patient has abnormal head posture. This is right. So definitely patient has a sixth nerve palsy. Don't conclude that. Go to Hirschberg reflex test, go to cover test for distance, near, ocular motility. That way we should plan. But I must tell you one thing, that if you want to check, have a systemic approach. Visual acuity should be first most of the times, because sometimes visual acuity and stereopsis can be changed once you occlude the eyes. So that's important. And look at this patient. These are all, when they come into your clinic or inside your examination room, you can see a big head tilt. Whenever somebody has a head tilt, if they have acute condition, you will think about skew deviation or anything like that. But most commonly, what do you think? Patient has superior oblique palsy. If they have superior oblique palsy, what they have? They will have one eye at the higher level, hypertropia. If they don't have, sometimes DVD like this, the patient can have. We will go through the cases later, but I just want you to understand what is the importance. Sometimes you may not be able to elicit this abnormal head posture. Parents have to give you photographs, or nowadays most of them have photographs, and you can also look at the videos sent by them. It's a typical left head tilt. It's a congenital superior oblique palsy this patient had, and then we had to intervene, and these are the pre and post-op pictures. She was not even allowing us to do estimation in the clinic, but always we used to depend on the pictures sent by. But how do you do surgery in a kid and infants and toddlers? Sometimes you'll have to base your surgery on Krimsky's test or Hirschberg reflex tests and the ocular motility, or the combination. So most of the times you'll be able to do the cover test, but sometimes you will not be able to. I just wanted to give this overview. One of my fellow Ajinkya prepared this algorithm for abnormal head posture. The first case there is because of scleritis. When they have scleritis, they can have pain. Because of that, they may not move. And the second case was because of oblique astigmatism. With the pinhole, you can see that it has improved. The third picture on that, she has a chin down position because of She had refractive accommodative esotropia. Once we gave glasses, she became all right. Fourth case, where you can see the visual field defect, she had that kind of abnormal head posture. She had resolution of this hemorrhage in the parieto-occipital region, and then it improved. The fifth row you have already seen, abnormal head posture because of the glasses, scratches in the glasses. Optical, this you need to remember all the time. So it's strabismus, it's nystagmus, it's any kind of infection, it's refractive error. And the last picture, you can see chin elevation because of the ptosis. So what's the algorithm whenever you see? These are all good to have this on your presentation. Close eyes, one eye. Always see whether closing one eye, abnormal head posture persists. This is the simplest thing you can do in your clinic. That's mainly because of orthopedic reason. If it disappears on supine position, then you need to check. If it disappears, means it's something ocular. If it disappears and if it persists, even in supine position, it's ocular. Otherwise, it's vestibular. Excuse me. Sorry about that. So then if it is ocular, do the patch test, and if it is worsening, and look at whether it is improving with the pinhole test. All that you can do it with just looking at whether it is persisting on closing one eye. This way, you can come to a conclusion. Once you do this everything, it can be optical also, which you need to look at other tests in this kind of situations. So other points you need to remember is position of the lids. Lids and the globe position is very important. So in this patient, you can see the patient has a very broad nasal bridge and also epicanthal folds, very typical feature of pseudo-esotropia. In this patient, what is happening? The patient looks like there is exotropia. This is because of the angle kappa abnormality. Positive or negative can lead on to this pseudo-strabismus picture. But once you do cover test, she does not have any kind of deviation. Here, what you can see is the lateral canthus is little bit upward, and also the position of the lids, the lower lid, if you see, it usually has a curve. What is happening in her case is it is almost straight. Compare the upper lid and the lower lid. These positions also can give rise to, because these are all part of inspection, observation, abnormal head posture, facial features. Sometimes the patient can have a frontal bossing or hydrocephalus, or they can have a craniosynostosis where there is a abnormal skull shape. With that also they can have strabismus. So these are all different aspects what we need to see. This patient, if you see what you can see, immediately what you can see is this size outward, and also there is upward movement of this side. This is the way she looks. But if you look carefully, what else is there? Look at the position of the medial canthus. Look at the position of the lateral canthus. Medial canthus, lateral canthus. She has this anti-mongoloid slant. Why it is important? With this change in the slant, they can have path of the extraocular muscles can be different. We call it as heterotopia of the pulleys and the path of the muscles. With that, they can have a pattern strabismus. As you can see, this girl had that kind of pattern where there is 35 prisms of exotropia in upgaze, which increased to almost 55. It's not that you need to, because this this observation, whatever I showed, it takes 10 or 15 seconds before you do things. Don't directly get into the business of doing cover test or Hirschberg reflex test. Spend at least 20-30 seconds. Once you have seen many cases, it becomes easy to kind of incorporate in your checklist. Okay, let me look at face. It applies even if you keep a patient over a slit lamp. Just look at. Don't just look at cornea or cataract. Just look around. You will get the answer most of the times. Excuse me. What you can see here is I'm using a translucent occluder here. Under the occlusion, the occluded eye, you can see the eye is going up and also out. When I change it to the left eye, now the left occluded eye also is going out and it's also going up, but the amount of deviation is not so much. So when there is a differential amount of deviation, what do you call? It could be because of paresis or incompetence, or it can be because of the dissociated strabismus, as in this case. You are getting a dissociated amount of, the amount of deviation with the right eye occlusion and left eye occlusion. Many people do a cover test in one eye and leave it. You need to do this kind of check also when you are trying to do this. I think I will take this light reflex test and then probably we can take some questions and then we can continue the part 2.
Yeah.
So in terms of, is it okay, Asha?
Yes, sir.
Okay,
Yeah.
Perfect. So with regards to the light reflex, most of us use this light, maybe a stick lamp light or indirect, but what you need is a very good torch light. As a resident or as a practitioner, you need to have a torch light, which is very small pen torch, which should not have any kind of scotoma, central scotoma. Most of the torch, if you use a big one, it will have a central scotoma. So you need to carry it wherever, because the torch light gives a lot of information. But as a strabismus evaluation, Hirschberg test, you can also look at the angle kappa, how it is seen, because that is a part which can be seen in Hirschberg reflex test. But when you do a cover test, you may not have anything. So positive and negative angle kappa, it's very important. And Krimsky's test and modified Krimsky's test, again, you use light source and then check the deviation. And Bruckner's test, you need to use some kind of direct ophthalmoscope or any kind of ophthalmoscope to have that. So this is what it is. You can see it's an oblique picture taken. It's not end-to-end picture. That's why I don't think that we are sitting obliquely. Whenever you are checking this, you need to directly in front of the patient, you need to sit at the level of the child or the patient. And you use a point source of light and see where the reflex is falling in the right side and also on the left side. Mostly, if they have strabismus in the eye, the dominant eye, it will be at the center, not exactly at the center, little bit deviation will be there. And then all of you know, 7 degrees, 15 degrees and 30 degrees between the pupil border and the limbus. But it's also important, and the visual axis and the pupillary axis, it can be positive and negative. Both can lead to esotropia, pseudo-esotropia or pseudo-exotropia. So this is close to limbus. I directly know what this patient has. This patient has a esotropia. You can see the reflex where exactly it's falling, not exactly at the limbus. The problem with this Hirschberg reflex is sometimes if the patient has very large strabismus, it'll have the reflex on the sclera. We may not be able to clearly see that. Even Hirschberg reflex has to go beyond. That's what we are trying to calibrate beyond the limbus. If it falls, what's the kind of amount of deviation? We are coming up with the algorithm. It's not so difficult. We can add another 15 degrees or so. So sometimes we have 100 or 120 degrees of strabismus, or not 120. Probably 90 is the maximum what I have seen looking at the medial wall of the orbit. So it can be close to 120 prisms or 140 prisms sometimes. So you can only measure 50 prisms in your set, or 95 prisms. So that's about it. This is Krimsky's test. Asha, I'll stop at Krimsky's test, and then we can take some questions.
Have some questions lined
up. Krimsky and modified Krimsky is something like, which is very important. Krimsky is straightforward. You have good eye vision in one eye. In this case, the right eye has good vision, 6/6. Left eye has a very poor vision. There are some prerequisites to do a cover test. Number one, they should have a relatively good vision. Probably, I would say, whatever the maximum chart in your vision chart, they can read 2200 or so. Second thing is, it's important that they have a central fixation. It's not that they have ROP drag because of the macula or the coloboma punched out scar. Then you will keep on measuring, but you will not find the neutralizing point. Central fixation, good vision, good ocular motility. Sometimes in 6-nerve palsy, if it is coming up till midline, you can still measure it. But if the eye is not even coming to the midline, you cannot measure. So in these kind of situations, you can do this Krimsky's test. Krimsky is when I place the prism in the non-dominant eye or the squinting eye, as you can see in the first picture. Modified is when I put it on the normal eye and see the centration of the squinting eye. Practically, I think modified Krimsky is very useful, because if you use a prism directly, you will have a parallax error created by that. You may not be able to see where exactly is the centration. So by using a prism in the normal eye, you keep on increasing till you see the centration of the left eye. As in this case, left eye has esotropia. So we are using a base out prism in that case. I'll just show this video how to perform this Krimsky's test, and then we can go for questions. So this is the same patient, whatever picture I showed. Cover test, you can see that oblique movement, some kind of fixation error there. This is Krimsky's test. I'm keeping on increasing. I can't see the centration. You can see even now it is not central. I'm doing a modified Krimsky now. Maybe I need to increase a little bit more. Now you can see that eye is centered. This is a approximate. It's not a guesstimate. It's an approximate amount of strabismus. We can check with this. Yeah, that's all I had for today. We can do the cover test and other different types of tests which are involved in motor test in the next class. Thank you.
Thank you, sir. That was a very illustrative lecture with all the videos and the pictures. So we have few questions, and also I wanted to introduce Dr. Soni and Dr. Praveen. They are our hot seats for today. Soni is a final year MS at Shadan Institute of Medical Sciences. She has a question for you. What is the time to patch the eye for diseased and normal eye to interpret?
Okay, this is basically you are asking what is the time of disruption of a fusion it is required to elicit the amount of strabismus or amount of latent or intermittent strabismus?
Dr. Soni, you can ask
No?
the question directly.
Okay.
Yes.
They can. Okay. Go
Good
ahead.
evening, sir.
Good evening.
Sir, I wanted to know the time to patch the eye for interpretation in, like, what is the time for normal eye and what is the time for the other eye, deviated eye, to know that clearly to know the
Okay. See,
amount
the
of
thing it's not like normal eye and abnormal or squinting eyes only we need to do. Which situation? Let us understand where do you need this patch test. If a patient comes with the, as I showed in my Krimsky's test, patient has very poor vision, has a manifest deviation, definitely it's there. Probably we don't have to do the patch test. Where it is required, patient is coming to you with the intermittent exotropia. Sometimes you can see the eyes are deviating, sometimes it's perfect. These kind of situations, to get the maximum amount of deviation, generally a 40-minute patch of one of the eye is required. It is not about normal or abnormal eye. Any eye you can patch and wait for 40 minutes and call them again. Having said that, for practical purpose, you can do it for 20 to 30 minutes also. When I was doing a fellowship in US, some of my mentors used to do a kind of half-day patch or overnight patch and directly come. So these are variable, but I would say 40 minutes is definitely possible to disrupt that fusion so that you can check the maximum deviation, how much the eye is deviating without any kind of accommodative component for the fusional component for that particular patient. Is it clear?
Yes, sir. It's very clear. Thank you, sir.
Want to add anything in this patching? Like we used to patch in the rounds till you come. So just wanted to.
Dr. Pradeep Sharma can
I think
share
what
his experience. I think
was saying was correct, that in cases of intermittent exotropias, there are two situations when we want to know. One is to differentiate between the simulated divergence axis and the true divergence axis. That is one. And the other situation is to know the full amount of exotropia. Because many a times the exotropias, when we measure, even for distance fixation, we may not get the full amount. And that's why we have come across people saying that after the surgery also there is a residual exotropia, partly because of this reason, that the full amount of exotropia was not detected. So one mechanism is that you make them fixate at far distance, not just 6 meters, but maybe 20 meters, or even ask them to look outside the window, as they say, of the clinic. So that is one way of doing it, but still that may not fully dissociate the two eyes. And so a patch is done. So these are the two situations in intermittent exotropias when we may patch. And as Dr. Ramesh has said, for convenience sake, we take it 30 minutes. Although Kushner has mentioned 45 minutes, and the older times, strabismologists have mentioned even 24 hours of patch, which was mentioned. But usually we find that a 30-minute patch would bring out the difference between a simulated and a true divergence axis, and that should serve the purpose. So, but yes, and that's another thing, like we don't differentiate whether we have to patch the good eye or the deviating eye. It is breaking the fusion. So any one eye, when you patch, the fusion will be broken the same way. So I think that is the important thing. I think Dr. Ramesh has very nicely put up the presentation on the observation. I mean, we would like to have some more questions if there are in that.
Yes. How do we rule out head posture due to refractive error?
Okay. Refractive error is mostly by exclusion. Okay. Refractive error, there are two situations which will come to you. For example, a patient is already wearing glasses and patient is not wearing glasses. So what is the checklist I will do is patch one eye whenever the patient has abnormal head posture, patch one eye, see whether it is going or not. Both related to ocular and the refractive error, it will go. once you patch one eye or occlude one eye. But the second thing what you have to do is, it's a little bit difficult to really demonstrate in the clinic, because with the occlusion or a pinhole, if it is related to refractive error, it will go. But the refractive error related abnormal head posture is, I would not say it's very common. It's usually exclusion, I would say. Most common cause, either it could be strabismus, ptosis, nystagmus. These are the top priority I would look into. Then comes maybe A pattern or V pattern or any kind of palsies like superior oblique palsies. That's the next three set of things what I would see. If it is something vestibular or skew deviation or anything like that, usually they won't come to us. I'm talking about a practical situation. Theoretically, anything can happen. I'm seeing what can happen in a routine clinical situation is, if they are really sick, skew deviations can be there with the vestibular or other things. In spite of this, if you ruled out strabismus, cover test, absolutely ortho in all positions of gaze. This is very important. All positions of gaze, orthotropic, no nystagmus, no lid drooping, pupils are okay. Obviously, no visual field defects, no pallor or anything, because sometimes even a visual field defect patients can have their abnormal head posture. These are all we have to do, should not conclude at the beginning. We need to come to this kind of exclusion one by one. In spite of that, if I can't find anything, then if I see whether the patient has refractive error. I have seen refractive error causing abnormal head posture in oblique astigmatisms and in hypertropias. Hyper in the sense hypermetropias, severe hypermetropias, especially when they look down, they accommodate more. Usually they try to put like this, their head. Once you give glasses, that's what even I showed it in the poster also. When you give glasses, they become all right. Not typical myopia, all these things will not lead to a kind of abnormal head posture. It's a long answer, but I would say you need to come to a conclusion by ruling out everything else. There is no one recipe like do a cover test, you have ruled out refractive error.
No, just
Doctor,
to add on that, sometimes
yes.
people who are wearing corrections and they have become undercorrected, they start peeping from the side because the side of the glasses is going to give them a little more refractive effect. So the prismatic effect is more. So many children, if they are wearing even myopic or hypermetropic correction, when they start peeping from the side, it may be the reason that they are undercorrected and it's time for them to change the glasses. So that's another situation which may become.
Very, very valid point, Dr. Sharma. And also in pseudophakic patients or aphakic patients, if the correction of hypermetropia is too much, they again try to do that.
Exactly.
And if you are given prescription, which is too much for the child, again, they will do this. So this is what I just wanted to share. After giving refractive error correction also, they can have abnormal head posture, as I showed in the scratch on the glasses. When you put occlusion in one eye, also she had, because she had a window of seeing in one corner. And then in the clinic, you can say that we did everything. Obviously, in the clinic only, we checked the glasses, which generally people should have a habit of checking the glasses. What's the condition, especially in children? So that also is important. After refractive error correction also, people can have abnormal head posture. But common things, think about common things first.
Dr. Amitava, can you share your experience with head turns and tilts in daily?
No, Dr. Ramesh has covered up very well, in fact, and Dr. Sharma has added whatever few gaps were there. Just one thing, when you get people with head posture, I tell my students that you see there is some gain for that child, that person. He may or she may be straight-eyed with that head posture. And it may be just a very feeble fusion. And, there is a tendency in students to straighten out the head in the primary case. And then this fusion may actually break at that point of time. And it may not recover during the time the child is in your clinic. So I always tell them here, don't have to touch the child. Let's get all the positives that are there. If the child is in alignment with that posture, he's fusing. These are positive. Such a person, if we do plan a surgical intervention, is more likely to, get a happy ending because he's demonstrating a binocular function. So that's about one thing I thought we should tell these students, that you don't have to straighten out the person all the time, when they come with head posture.
In fact, the moment the child walks into the clinic, he is the most attentive at that time because he is maybe a little scared, little anxious. So at that time, you should not miss the opportunity, because that time he is going to have a head posture. The best window for observing would be that time, especially people who have nystagmus. I mean, you would see them when they are coming in, they would have it, or you have to wait for the very fine line on the Snellens to make them read. Otherwise, you may not get the complete head posture. So you have to be very observant. As I generally say, the recipe in strabismus is OCIPE. Observation, as Dr. Ramesh mentioned today, I mean, that's the first leg. So you have to have very keen observation. But then that has to be coupled with confirmation by your simple tests, like cover tests he talked about, and the other things which we may be using, like Spielman's or Pluder or whatever. Then third comes the inference. And then is the planning and execution. So it's OCIPE. This is the 5-pronged approach which we recommend for strabismus. But the first thing, most important, is observation, because children may not give you another chance. So you have to be very observant in the first time when the child comes into your clinic, and observe and then note that one.
Thank you, sir. The next question is, does dilation of pupil alter the interpretation of Hirschberg corneal reflex test, and how reliable is it?
Yeah, dilatation is, it can affect, but you need to imagine what's the center part of the, pupil. This is usually a reason to, say that, okay, come on another day, pupil is dilated. Okay, that's a common thing. But I would say you can still get some information, even in a dilated patient. Kind of how much is the deviation, whether it is exotropia or esotropia. We can definitely make out. Pupil is dilated. Instead of 3 millimeter, it's around 7 or 8 millimeter. You can still imagine, because we have seen a lot of eyes. We know where the position is going to be. And it's not a measurement where you have to do a surgery. I will never do a surgery. But for a diagnostic purpose, it's still good enough. I cannot do the strabismus evaluation for near. Not possible. Pupil is dilated. They can't even accommodate. For the distance, both in a sensory case or in a patient with both eyes vision, you can just do an evaluation for diagnostic purpose, I would say. Not beyond that. Pupil is dilated, so what? You can do still ocular motility, right? You can still rule out Duane syndrome. You can still rule out Brown syndrome with abnormal head posture. They coming like that. So it can be still diagnostic, but not therapeutic. But I agree, there is a situation where intermittent exotropia comes. I need to know what's the control, all that. But you can fairly get a good idea about what is happening to the patient. I would not rely and do anything, any intervention, without doing a, undilated check for a strabismus evaluation. Limited information can be still got.
I mean, this is a generalization that Dr. Ramesh was talking about the pupil. In any case, you would remember that pupil size is not going to be the same. If there is a lighter iris person, he would have a little more dilated pupil. It may be around 4 or 5 millimeters, whereas another person may have 3 millimeters. But here we are more often going by the millimeters of separation from the center, or a slight off center that it's not exactly center, but slight off center that the reflex comes, the light reflex. So we will be talking about the difference between the limbus and this point in terms of millimeters. But this is not exact gradation for the purpose of surgery, but more for maybe in children, sometimes we may use that, but not for. But by the way, pupillary dilatation is definitely a no-no when you want to make an examination of the eye for strabismus, because then the fixation becomes affected. So if a person is coming with dilated pupils, you would have to schedule a visit another day in order to have a proper measurement of deviation, because at that time his accommodation would be affected, his ability to fixate would be affected. So you will have a difficulty in taking measurements. So that
Dr. Amitava had a point, I think.
Yeah, I just wanted to say that when I'm doing it in the clinic, I mean, where people have been posted to pick up strabismus points, I actually force them to say, I want you to tell me how many millimeters off the center do you feel it is. And we sometimes put a scale next to the patient to see you should, and I ask them to look at a scale to remind them of how much is a millimeter actually. You know, we tend to forget how much is a millimeter on the cornea. And then, you know, I tell them, see, look, a cornea itself is a scale of about 10 millimeters. So make a best guess that, okay, it seems to be 1 millimeter off, is it 2 millimeters off? And try to associate it with the millimeters, not just with the pupillary edge.
Correct. Yes, that's a nice point.
For squint evaluation in kids, can Krimsky be done as a primary evaluation? And if yes, how young?
You can do as young as 3 or 4 months if they have a congenital strabismus because of Duane or things like that. We can also do even in older patients, but as they get older, it becomes difficult, especially in toddlers. They don't like anything coming in front of their eyes. So still, you can just get one. In infants and toddlers, it's a different ball game. Don't expect, okay, I will make the child sit like this straight. Let me do Hirschberg. Then let me do uncover. It's not going to work. When you are dealing with an infant and toddler, inspection, I think for me, the inspection and ocular motility becomes very, very crucial. Then, after everything, just come back and sit and have a conversation with the parent. Come back. And when the child is looking at you, judging at you, what is it? He's not a harmful person. Let me go and put the prism once. Just measure how much it is. Come back. Take 10 seconds. Don't check. Okay, let me do. That's not possible. So you need to time the examination in a toddler and infants. It's not that you may be able to do continuously. Sometimes you have to put the child on the shoulder of the mother and then go back. And from there, you can do the Krimsky test. So it's a little bit of a tricky thing, like you do a refraction in an infant and toddler, very similar way, even the strabismus. But you can get a fairly, I would say, fairly good estimation of the amount of deviation by doing a Krimsky test, even if they have good vision in both eyes. Dr. Amitava and Dr. Sharma, you have any other points and tricks to add to that?
I do want to add, you know, I think we don't have electricity, so I have come down to my lamp on the inverter. So one trick is, you see, when you have an apprehensive toddler who's really worried, whatever you want to do, it's I sometimes do it on the mother. You know, I take that instrument and do it on the mother. That reassures the child very often, and then, you know, they're more receptive to me doing the same thing on them. So that is a little trick which I think people can try, you know, when they're dealing with apprehensive little kids.
So how reliable is Hirschberg test over PBCT in younger kids? For a
never 100%, never. It's doable. I would say maybe infant and toddler. If you do a strabismus surgery, 30 to 40% of the kids will be based on Krimsky and Hirschberg test in the true sense. It's just not possible to accurately do a complete assessment. That's why even if it is Hirschberg is such an old test, still it has got some value in these kind of situations. What is again required is, like in them, what do we do surgery wise? Most often it's an infantile esotropia surgery, or any kind of esotropia surgery is the most common we do. Very rarely we do some kind of Duane syndrome surgery, maybe some nystagmus surgery. So if you take the infantile esotropia, we need to have, usually it is between 30 to 40 or 45. One size never fits all, but most of the times it fits to that particular patient because we still want a little bit of undercorrection. So if you ask me, direct answer is no, it is never same, but it is feasible and possible in infants to decide our therapeutic dose depending upon the Krimsky's test. Dr. Sharma and Dr. Amita will have more experience. They can share how much percentage of their patients are kids and they do their surgery based on this.
So I think we have to go by the Prism bar cover test in most of the cases whenever feasible, even in the children, whenever we can get hold of the Prism bar measurement, that is going to be more reliable. In, let's say, a child who's just about 7 months and you have to do a surgery and he doesn't allow the thing, then you may go by the Hirschberg. But yes, there is a pinch of salt that you have to remember. There have been several studies in order to quantify the Hirschbergs, and they have all come out with this that the reliability is not 100%. And now there's another, I think, revived interest with the gaze tracking studies. Though the web cameras on that and with the gaze tracking, they are trying to do it. The problem here is that we are trying to see a chord measurement with an arc measurement. So that is the reason why there is a fallacy between the Hirschbergs and the Prism bar cover test, because that is a more rotational actual value when we do with the Prism bar cover test. So the most reliable, whenever possible, always go by the PVCT. When you don't have that possibility at all, then it's like the lesser evil. Then you can go with the Hirschberg's test. The Krimsky is also actually a modification of Hirschberg's.
Yes. Dr. Amitava, do you want to add anything in this? Like, how do you deal with younger kids in your OPD before surgical evaluation?
So that's true what Professor Sharma and Dr. Ramesh have said. I would much prefer the Prism bar cover test because it gives me more precise measurements. And that's what I want. I mean, I know that now he's seeing with each 4-year intern when we are switching the cover. In these children, we're not very sure this thing. But we do have to kind of straighten out the eye in those tiny little kids also, because we want to align them as much as we can so that all the neural development proceeds as normally as possible. We more often than not succeed because we actually put it within the fusional capacity of the child, and so we kind of continue to do that. But those are uncommon things. Very tiny kids who can't, who won't prefer, and listen to you. It's not easy, let me tell you, when the postgraduates, because when they go to this orthoptist clinic and when they try, they realize that when you are sitting close to the kid, your face is the most attractive to the kid. Especially if you're wearing specs and you have mustaches and you have all the funny things. He is not interested in looking at the Snellen's chart, whatever you may have at 6 meters away. He is more interested in what is in your hand and what does your face look like. The human face is the most attractive object. I have even now started having children look at their mother actually. I make the mother stand behind my shoulder, give the kid to the father if possible, and let the mother attract the child. And then I may do some tests to see how's the fixation doing. Using the mother's face as a fixation target.
You can actually use the fixation animated toys on the screen. So you keep changing. Ask your assistant to keep on changing by the time you're doing. And each time there's a new picture popping up, the child is curiously looking there. So it's an apple, a turtle, or whatever. I mean, then he keeps, and you can keep on playing. And he's interested in the television going on at the far. So his interest could be in that.
Thank you, sir. That are such good tips to take an examination before surgical evaluation. Yeah, and here I would like to conclude today's session. Thank you, Dr. Ramesh. It has been very nice to hear such an illustrative session, and I am hoping for this second session of our examination. And thank you, Dr. Pradeep, and thank you, Dr. Amitava, and thank you, Dr. Santosh, for your valuable time. And I would also like to thank our two hot seaters today, Dr. Soni and Dr. Praveen, for making this session interactive. And by this, I would like to conclude the session. And we'll be meeting in the next Friday with the examination of Squint Part 2 by Dr. Ramesh.
Thank you, Asha.
Thank you. Bye-bye.
Bye.
Thank you.